They can't keep their eyes open. They're so exhausted. They can't work. They can't take care of their house. They can't do anything fun. And it's affecting so much of their life, financially, emotionally, physically, everything. It's just overshadowed by this fatigue. And when we can work on ways to think about fatigue,
Welcome back to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained expert in Ehlers-Danlos syndromes. Today, we're going to be talking with physician assistant Rebecca Gluck. When Rebecca reached out to me a number of months ago, I was so excited because she had such a fabulous background working with people with connective tissue disorders. Rebecca began her clinical career in physical medicine rehabilitation and gained specialized genetics experience working with Dr. Clair Francomano and supporting patients with hereditary connective tissue disorders. Rebecca also serves on the Ehlers-Danlos Society's Medical and Scientific Advisory Board and Road to 2026 Research Committee. At Bendy Bodies, she brings a unique blend of clinical expertise, patient education, and compassionate support to help clients feel informed, validated, and empowered. This podcast is for education only and is not a substitute for personalized medical advice. Stay to the end for a hypermobility hack. Here we go. Well, I'm so excited to be here with Rebecca Gluck. We've been wanting to do this for a while. So thank you so much, Rebecca, for coming on the Bendy Bodies podcast.
thank you. I'm so glad to be here.
I know that a lot of people have really enjoyed working with you already, doing edu-coaching, but a lot of people don't know a whole lot about you. So I think this is going to be a great opportunity for people to learn about your background and what kind of patients and clients you've worked with. And it's going to be, I think, really, really helpful for a lot of people. And I know that you and I have spent so many years hearing people's stories across a lot of different healthcare settings. And I know a lot of people are, really confused right now. What do you think is making it so confusing?
I think this is such a great question because I think so many people out there are feeling so confused and overwhelmed and honestly don't even know where to start. And what I've really seen consistently from working in a very specialized genetics clinic with Dr. Clair Francomano, to my years of EDS Society, working on the helpline, virtual support groups, moderating a lot of different online forums, and of course, in my current work now with edu-coaching is that people today have access to more information than ever before, which is amazing and can be so helpful, but it can also leave people feeling stuck because they're just so overwhelmed with all of that information and they're just unsure what applies to them. And they're trying to figure out what's accurate, what's relevant to them, who they should see, they should see first, what to try, what to avoid. And they're really getting different opinions everywhere they look.
Yeah, exactly. And it's what is the next step that I should take that's going to be most beneficial for me? And I feel like you have different experience than I have. We have overlapping experiences, right? So you have been in some of these online communities where I feel like there are more people giving medical advice than, us that are medical professionals. Like we know to be very careful, right? But I feel like in a lot of these communities, you'll see patients telling other patients, you should do blank, blank, blank. And they'll say like, I benefited so much from this. And they don't know like, should I or shouldn't I? But you and I know from talking to people that they might on the surface look very similar, but people are so different. And I think that that's a key message that I want people to hear is that if somebody suggests something to you like, yes, you should definitely, maybe look into it or whatever, but please do not take someone else online telling you should blank as like definitive advice, because while your situations might seem similar on the surface, there is a very, very strong possibility that they are very different. Would you agree with that?
Oh, definitely. And I think the online forums are so helpful and so valuable because for so many people, that is really how they are putting pieces together. And that's where they're finding information that ultimately leads them down the path of the help that they need. But at the same time, there is so much misinformation out there. And a lot of it is presented as fact, like this is what you need to do. this is what helped me, this saved my life, this is the only diet that you need. I mean, there's endless information out there. And for people to try to sort that all out on their own is really challenging.
Yeah, absolutely. So they often get completely different messages, right? Whether they're talking to a clinician, if they're reading an online community, whether they're using AI tools, which, we're going to talk about that too, because those can be super helpful, but you obviously have to take everything with a grain of salt. Or if they're looking at their test results, like they're getting different messaging. So, what do you think people should do about that?
Yeah, and this is such a common problem. I see this probably daily where people are coming in. They have all these different messages from all these different places. Someone might Google their symptoms and then they go through and read a bunch of forums and then they see some social media posts and then they put it into AI and then they go and see their primary care doctor or a specialist or a physical therapist or many of each of these providers. And each of them may be talking about the same symptoms, but they're coming at it in a totally different way. And I think what's really important to remember also is that each person's experience with these conditions can be very different. So even if the diagnosis or the label or what we call the symptom is the same, it can be coming from a different source. There can be different underlying causes. And what works for one person, like we mentioned earlier, may be completely different for another. And this really can also trip clinicians up because what they saw in their patient with EDS yesterday may not apply at all to the person sitting in front of them. So even someone who says, "Oh, I've had a few EDS patients," that doesn't necessarily mean that they can apply that, across the board. So I think so much of this information feels really conflicting to patients, not necessarily because the information is wrong, but not because it's not specific to that person.
Yes, it's that specificity that is so important. So I really appreciate that. And speaking of AI, and again, we both use it, and I think it's fantastic. And I use it for a lot of different things. But you have to be so careful. I had a patient who put their labs into AI and sent me a message on the portal, and they were panicking because they thought that their labs, well, the AI tool told them that their labs could show that they had cancer. Like these results suggest that you might have cancer. And this person was like freaking out. Like I looked at it and I'm like, I do not think you have cancer. Like I would not worry about that. Like there was another explanation that was so much more logical. So yeah, we just have to be really, really careful with those things. Yeah. And I know you and I have talked about this quite a bit. And I think it's really important. Not only AI now, and social media, but we also have things like direct to consumer testing. We have direct to consumer testing for so many things, and including genetic testing. So, how do you think those things have changed the way that people try to make sense of their symptoms?
And this is such a relevant question because there's really been such an explosion of tools that people are using to try to make sense of what's going on with them. And I think each of these could have their own podcast episode on their own as a standalone topic because there's so much to say. But I'll kind of hit one point at a time. I think kind of like what we mentioned earlier with social media, it can be so helpful because it gives people that validation that they're not the only ones going through this. They're not alone. This is something that is actually real and it's happening to other people. And it can expose people to different possible explanations for their symptoms. So there is really value there. But there's such a huge range in the quality of the information that's out there. And I think the key takeaway for people is to really check where that information is coming from. Is it a reliable source? Is it coming from a scientific organization or a doctor who is knowledgeable and certified and that is their area of practice? Or is it from some random person who may be giving good information but may not be? Um, and on kind of that same vein of maybe giving valuable information or may not be, that's kind of the key to AI. It is such a great tool. I use it all the time for generating, organizing information, generating ideas. But people really have to remember that it's not diagnostic. Like your patient who is scared about the cancer, AI cannot diagnose you with anything. It's taking the piece of information that you give it and looking at that narrowly and not taking, it doesn't know anything else other than what you put in it. Um, and it often makes mistakes. Like it often makes really big mistakes. If I had $1 for every time it said to me, "Good catch," it's it's not a perfect tool. Um, and it often presents information in a way that makes it sound much more certain than it really is. When there's often a lot that needs to be figured out in the alongside of that. So it's a great tool. But it's a tool. And like you said, everything has to be taken with a grain of salt and, double checked. And I love to talk about genetic testing, particularly direct to consumer genetic testing, because this is such a great question that people are asking a lot about with EDS and HSD specifically. Um, and when we say direct to consumer testing, we're talking about testing that people can order online themselves without a doctor. So it's not like they're not seeing a genetic counselor, they're not seeing a doctor, they're ordering a test online. And there are quite a few issues with it. Number one being that the reliability varies a lot. There have been studies that show that some of this testing is kind of like flipping a coin, whether the answers, the results that it gives you are even accurate. So that is, not great. But even with reliable labs, with genetic testing, results are not straightforward very often, and they need to be interpreted in clinical context. And if you're not working with a clinician who's experienced in genetics, you don't get that piece. And often results are showing things and the reports are not clear. And they say, like, they list off all these genes, and people will say to me, like, I tested positive for 11 types of EDS. It's like, that is not possible.
Right.
So,
Right.
I think it really is confusing. Um, and I think the key kind of takeaway from all of this is that what I found is that it used to be that most people had no idea what was wrong with them. And now many people just have way too many ideas of what could be wrong with them. And I think it's tough. It's tough to sort through all of that.
I made a few notes while you were talking because, yes, you made so many excellent points. So one, I'm sure you've seen this when people say exactly that. I tested positive for 11 types of EDS, and then you ask to see the report, and then they show you the report from these direct-to-consumer tests, and you realize that the reports are written in a way that is so misleading. They're written like things are much more absolute when really they're much more nuanced, and they might have variants of uncertain significance, but the report is making it sound like they are much more certain. So I feel like people need to understand the nuances, and that in general, if you're on social media, for example, and people are saying all these like absolutes, that should set off a little warning sign. Whereas if they're talking about things in a more nuanced way, that's probably more accurate, even though it's not as sexy. So it's hard.
Yeah, I think what you said about how there are no absolutes, I always tell people that if you see always or never, that is usually a sign that it's not a reliable source, because there are very few, if any, always and nevers in the EDS and HSD hypermobility world, because there's so much variability. And I think those always do this, never do that. Those are kind of red flags, like, okay, let's double check this.
And your point about AI is such a good one. I was using it the other day for it was scribing for me, right, for a patient's visit. And at the end, it told me that the labs were from February of 2027. And I'm like, wow, you can predict the future. I'm like, how does it make a mistake like that? But anyway, um, so thank you for all of those points. And you were talking about this just a second ago, but I want to ask about how confusion around diagnosis and how this contributes, including uncertainty about whether a diagnosis is needed when genetic testing is helpful, and how much weight to give labels.
This is a great question. And I think a lot of people who suspect that they have a hypermobility related disorder, getting the official diagnosis can become somewhat of an obsession. And I think it's really important to kind of talk about where and how it can be helpful. So, for many people, getting that official diagnosis can be really helpful. It gives that validation of, okay, this and a name, this is what is going on with me. I can describe it. It gives them that language to finally explain what they've been experiencing. Um, and it can help, communicate with providers across healthcare systems. And there are definitely benefits. But I think what often happens is that people expect that diagnosis to do more than it can. So they're expecting it to fully explain all of their symptoms, or to kind of give a clear roadmap of what to do next. So it's like, okay, now I have this diagnosis. Now all I have to do is follow the plan. And unfortunately, we're not at that stage yet where we have that. If you're diagnosed with X, you just do Y and you'll be, cured. And unfortunately, diagnosis is often not the magic answer. I think in many ways it can actually be the beginning of the process of figuring things out and not the end. Um, and I think, talking about genetic testing again, it often comes up in that similar way that people often hope that it'll be that definitive answer that explains everything. And now this will give me, all the tools that I need. Um, and, specifically, there's a lot of confusion because in the disorders like hypermobile EDS and HSD, we don't have that genetic test that can confirm the diagnosis. And genetic testing is used to rule out other conditions when there are specific concerns for those conditions. So, depending on the situation, that can sometimes add a lot of clarity. We've ruled out things that we are concerned about, and now we can move forward. But like you mentioned earlier, with variants of uncertain significance, sometimes it brings up more questions than we had before. And sometimes, like if there's a strong family history, you are still managing the person based on their symptoms and their family history and not necessarily a genetic test. So, you know, I I think the label is helpful. The diagnosis can be helpful. It can help guide and give people a framework that they're working within, but it is not that, magic solution that will solve everything.
Right, right. When you get the diagnosis, you still have the symptoms and you still need to figure out what to do with the symptoms and how to it's not like, oh, yes, you get the diagnosis of hypermobile EDS or HSD and then there's this super clear path. I mean, we help people with that a lot and help them figure out how to prioritize and everything. But yeah, that's such a good point. And I feel like the terminology also contributes to confusion over time because we've had so many different changes in the nosology, right? And people are told all the time, you're just hypermobile or you have benign. People are still using benign joint hypermobility syndrome, even though we're not supposed to use that anymore. You still see that in people's charts and things like that. How do you think that terminology contributes to the confusion?
I think it plays a big role, and it's very relevant now because by the end of this year, early next year, they are coming out with a new classification for EDS and HSD. So this is something that's really relevant right now because things may be changing again soon. And the goal of classification updates is to as scientific knowledge evolves, we want to best group people in ways that makes the most sense to best coordinate care and to get them the care that they need. But these name changes can be really confusing, both for patients and also clinicians. Um, and most practitioners out there cannot keep. I would say every no clinician out there can keep up to date with every single condition on Earth and all the changes, and because this isn't unique to EDS and HSD, terminology updates happen across medicine. Big in the news was PCOS just became PMOS, and that's a huge change that is affecting millions of people. Um, and I think we see this a lot, across medicine. And it can take years for changes in terminology and criteria to filter through all the different systems, the coding and the charting and just how people are used to what they're used to. And um, change is difficult on many levels. So, um, I also still frequently see people who are being diagnosed today with terminology that is pre the 2017 criteria. So they're kind of 10 years behind. And that benign joint hypermobility syndrome is the worst because there are people being diagnosed with that or who have it in their charts, and their condition is so far from benign, and that is really a disservice to people. So it is something that is there. It's part of medicine as things, we can't avoid those changes. It's part of how it all evolves. But, recognizing that if you get one diagnosis and then the next doctor that you see says that diagnosis doesn't exist, who gave that to you? And then you feel like, do I not exist? Does my, does my condition not exist? It's, a lot of it's just the name, what you call it doesn't change the symptoms that you're having. But understanding some of that background about the different names and how they changed and what it used to be before it is what it is currently can help give people the context to understand what clinicians are telling them, what they're reading online. If they pull up an old research paper, they can understand, like, oh, EDS 4 is now called vascular EDS, and that's talking about the same thing. So having that information can kind of help put all those things together.
So why does it sometimes feel like physical therapists, PCPs, specialists, and online spaces are often describing the same person, but in completely different ways?
Yeah, it's a great question. I think that each of those different perspectives are kind of looking at a different piece of the puzzle. The famous story of the blind man and the elephant, and they're each feeling a different part. And like, oh, this is a hose, this is a wall, this is a, and they're all approaching the same thing, but from a different angle and a different piece. And I think, a PT is looking at movement and stability, and a GI doctor is looking at the GI tract. And, online forums are a lot of times looking at the emotional aspect of it. And a research paper is looking at it from a physiologic or a biologic or a genetic perspective. And it you kind of have to put all those pieces together to be able to understand the full picture. And I think that's what, a lot of what we do is take all those pieces that people are bringing us from all the different sources where they're kind of gathering them and saying, like, now what do I do? What is this? What is all of this? And that's where we can kind of often come in and help people, you know, look at that bigger picture. And that's something that's really privileged to be able to do, because I think it's hard when you're trying to do it for yourself as a patient, because you're so overwhelmed, and it you're a lot of people are not familiar with the terminology, are not familiar with a lot of these different concepts. And your average patient does not have a medical degree, and trying to educate all yourself on all of these different things while you're really not feeling well because you're struggling with all these things is really, really hard.
Yeah, I'm glad that you mentioned about, well, most people are not medical, professionals. I have a lot of medical professional patients, a lot. So even people who are physicians, PAs, physical therapists, et cetera, and have that background, it still can be really hard when it's your own body. It can be really hard to sort out, like, what's the next step. And you have maybe a lot of extra education that maybe a lot of other people don't have. But it's still, like you said, it's still so hard to keep on top of a single space. Not that this is a single space, because it affects every system, right? So it's like trying to keep on top of things in the world of hypermobile EDS and HSD and other forms of EDS and other connective tissue disorders is like big, right? That's a really big thing to try to keep on top of. But I find that is very true for a lot of clinicians also. They've also been gaslit. And I cannot tell you how many times, and you've probably heard this too, because I know you have seen veterinarians, and I know you already have seen a number of medical professionals, medical students, et cetera. They often will say to us, right, if I'm struggling this much, how is somebody without a medical background supposed to figure this out or sort this out or figure out the next step?
Yeah, and I hear that, and as you were speaking, I was thinking that exact same thing. Like, I've spoken to so many people who have told me, I am a doctor. I have been a practicing doctor for 40 years, and my doctors won't take me seriously. I can't even imagine how people who don't have the experience that I have, who don't know the system, who can't talk the speak the lingo, are managing with all of this. And it's true, it's all the more difficult, and that's where support becomes even more important and more helpful.
Yeah, definitely. Let's talk about the EDS expert. So, I mean, obviously, both of us are EDS specialists and we have a lot of expertise in this area. But we also see people talking online about, I just need to find an EDS expert. What do you think people mean when they say they're looking for an EDS expert?
You hear this all the time. And I think people are often searching for that one person who can come and tie everything together, almost like a Dr. House type of figure. They'll just come in and in one visit, answer every question at once and solve every complexity and wrap it all up with a neat bow and say, here is the answer. And I think that's the kind of unicorn that they're looking for out there.
Right. So while we specialize in these conditions, I think a good way to describe like what we do is we're like quarterbacks. We can help them kind of, navigate a lot of the different moving parts. And I often tell people, I'm not the smartest person in the room by any means. I am somebody, though, who doesn't give up. So I'll just keep digging and looking and trying to figure out, what are some other levers that we can pull? What are some of the lowest hanging fruit that we can try? Because while like nobody has enough expertise to solve like every part of a person's problem, because I remember early on Dr. Chopra telling me like you will need a team. You will need to have neurologists, endocrinologists, neurosurgery. Like you can't solve or treat like all of the things that people are going to present you with. So in that way, I think yes and no, there are true EDS experts. Do you think that's accurate or no?
Yeah, so I think, in the way that I just described earlier, that people, who are searching for that one person who can come in and solve everything, honestly, I don't think that exists. And I was going to say the same, thing that you were just describing. I don't think there's any one person who can solve every single issue, and certainly not in one visit, because these are multi-systemic conditions, and it takes a team approach to really address everything that's going on. And there are absolutely excellent clinicians out there who have so much experience in these areas and who really take the time to evaluate and manage these conditions thoroughly and to not give up and to keep trying and to keep thinking through. And I've been so fortunate to learn from and work with people like this, like you, like Dr. Clair Francomano, like Dr. Alan Hakim, who really are, dedicated to doing as much as they can for their patients. Um, and, even these highly specialized providers still have to refer out. It's impossible to do every specialty at once. You cannot do neurosurgery because that is not your training or your expertise. And that is, you can refer, but, and no one person can solve everyone's problem. So I think a much more realistic way for people to approach this is not looking for the one expert, but ideally to be able to build a network of expertise, build a team of people who are, going to help you and can get you to that point.
Love that. We are going to take a quick break, and when we come back, we are going to talk about a real life example of a type of client that Rebecca and I often work with, and what some things are that might be helpful. And also, we're going to talk about genetics and a little bit more about rare types of EDS and how the care might differ, whether you have hypermobile EDS, HSD, or a rare type of EDS. We're going to take a quick break, and we will be right back. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Okay, we are back with physician assistant Rebecca Gluck and talking about so many things that we want people to know about hypermobile EDS, HSD, and also rare types of EDS. And we were just talking about the team. So whether you have a rare type of EDS or hypermobile EDS or HSD, you need a team, right? But how does the care differ between these? And I know that you have more expertise dealing with the rare types of EDS than I do because you worked with Dr. Clair Francomano for a number of years.
Yeah, and this is a great question because there are a lot of similarities across types of EDS, but there are also key differences. And I think that in all types of EDS and HSD, care is usually primarily guided by the symptoms someone is having. So, for example, if someone doesn't have any GI symptoms, they may not need a GI specialist on their team. Um, where it starts to differ is in terms of diagnosis and where how genetics plays a role. So as we talked about earlier, for EDS and HSD, there isn't currently a genetic test. So genetics is often not a part of confirming the diagnosis. And in general, care is more clinically based, more symptom driven, and specialists involved as needed, building that team like we talked about earlier. In some of the rarer types of EDS, genetic, in really all of the rare types of of EDS. Genetic testing is pretty central in confirming a diagnosis. And these patients are often identified and followed through genetics. So that tends to be their home. Um, and some of the rarer types of EDS also often require more structured screening. And these patients are often identified and followed through genetics. That is their kind of home. And a lot of these conditions also require more structured screening. So, for example, in someone with vascular EDS, even if they don't currently have any vascular symptoms, vascular screening regularly is usually required because of that high risk of aneurysms. Um, and even then, the screening and management are often still guided by the individual's personal and family history and not just their genetic test results or their diagnostic label. So across the board, that individual piece is still there, there are not, like we said earlier, that always and never really doesn't exist here because it has to be individualized to the person.
So, what about in your experience working with Dr. Francomano? What do you do about the patient who presents phenotypically? So, the clinical picture looks like vascular EDS, but you do the genetic testing. You and I had a case of this the other day, a coaching person who I'd seen, you've seen, and the clinical picture looks very much like vascular EDS, but the genetic testing comes back negative or maybe some variants of uncertain significance, but certainly not definitive for vascular EDS. In your experience, how is that patient often managed?
Yeah, it's a great question. And I think it applies across genetics, not specifically to EDS. So the general rule of thumb is that we treat the patient according to kind of the closest match disorder. So, you know, if they really look like vascular EDS, if they really look like Marfan syndrome, again, depending on what the symptoms are, what the family history looks like, often it would be managed that way. So, like that person that you were talking about that we had seen, I recommended that they have a baseline vascular screening because they had an aneurysm, even though they didn't have, and they had other things that were suggestive, like this really seems like vascular EDS. I think baseline vascular screening would be helpful in that case, even though there aren't any published guidelines that recommend that. And that is something that is tricky because it gets tricky with insurances and all sorts of other things, because without that diagnosis, um, insurances say, like, why does this person need a full body MRI? That doesn't make sense. And then, it can get tricky. But I think as a general rule, treating people according to kind of the closest condition that matches. If it's a really close match, then we can often kind of go by those guidelines.
Okay, so let's say in an example like this, where phenotypically they look like vascular EDS, but the testing comes back negative, they might be treated like they have vascular EDS, but they're not going to necessarily receive the diagnosis of vascular EDS because the genetic testing doesn't confirm it. Is that accurate to say? Because of course genetic testing continues to evolve and we continue to get more and more information about these variants of uncertain significance. So it's really a diagnostic conundrum.
It is. And this is kind of where the art of medicine comes in, kind of
Mhm.
beyond the science, because, and there's differences of opinion across geneticists. So some geneticists will say, you meet the clinical diagnostic criteria for vascular EDS. This looks like vascular EDS. I'm going to call it vascular EDS, or
Mhm.
genetically negative vascular EDS. And others
Mm.
will say, well, the genetic testing is confirmatory. We can't call this vascular EDS. I'm going to call it connective tissue disorder unspecified,
Uh-huh.
and with vascular EDS type features or whatever they're going to call it. So the
Mhm.
name can sometimes be clinician specific. And
Mhm.
I think you have to weigh the risk benefits because, for example, in vascular EDS, like we were talking about, surgery is very high risk, and you really, really don't want to do surgery unless it is really necessary. If that person in question doesn't actually have vascular EDS, surgery might be pretty safe for them. And putting surgeries on hold that would really improve their quality of life or would, help treat something sooner, like we would if they have vascular EDS, and a disservice to them if they don't. So it's always that balance. We don't want to overdiagnose people and, restrict them in that way. But we also don't want to underdiagnose people and, expose them to risks that they shouldn't be exposed to.
And I think that you and I should do a follow-up discussion about the red flags and be a little more, specific about what we're talking about, because I feel like there might be some people listening right now that think, oh, I have some things that are consistent with vascular EDS, like some of the easy bruising and bleeding and that kind of thing. But in this case, we're talking about there are some very highly specific features that make us worried about this particular person. So I don't want people to listen to that part of the conversation and think, oh my gosh, they're talking about me. Maybe we are, maybe we aren't. Of course, we don't know who all the thousands and thousands of people that are listening to this. So I think it would be helpful for us to come back and have another conversation about red flags and how those are handled and things like that. And so I would encourage people to send in questions for Rebecca for that future conversation, because I think that would be very helpful, because the whole genetics conversation and when should genetic testing happen and the role of the geneticist and all of that, I feel like we could do a whole nother episode on that. So please send in your questions, because that's really helpful for us.
Yeah, thank you for pointing that out. I think that's so important because the way the diagnostic criteria are now, a lot of the, particularly for vascular EDS, which I know is talked about the most because it is the scariest, the most famous, scariest, type out there. Um, a lot of those minor features are very non-specific to vascular EDS. And a lot of people in the world can have them and not have vascular EDS at all. So we're talking about when a geneticist or another, very experienced clinician suspects EDS, but the genetic testing is negative, then these decisions need to be made on that level. But for people themselves, if you are concerned about vascular EDS, it's really important, to get that figured out one way or another, because you definitely don't want for yourself to say like, oh, I'm not going to have that surgery because I'm scared I won't have vascular EDS, that I might have vascular EDS. So thanks for bringing that up. Definitely, it's a big point of a very common point of, confusion and concern for people.
Yeah, that some of the things are more specific and others are more general and affect a lot more people. So if there isn't one central expert, what should people realistically be looking for in a practitioner?
What I often tell people is that the majority of people are very unlikely to have that full dream team of EDS experts, because that framework honestly just doesn't exist in most parts of the world. Unfortunately, we're just not there yet. That's an option for most people. So what's often much more realistic and honestly more helpful in most cases is finding providers who are willing to listen, willing to learn, and willing to work collaboratively as part of a broader care team. And, I know that's easier said than done, but that is the key. If you can find those providers who are willing to listen to you and to learn, and who are humble enough to say, I don't know a lot about this, but I'm going to go do some research. And thank you for sharing what you've learned. And I'm going to read your notes, and I'm going to read the article you printed out to hand to me. And I'm going to talk to colleagues, and I'm going to figure this out. And that's the key of who you're looking for.
I think sometimes clinicians are in a really difficult place, because I see patients online all the time saying, I wish they would say they don't know. But at the same time, I see people criticizing people who don't know how to pronounce Ehlers-Danlos. And it's like, there is so much that people have to know. And I wish that people would kind of, give the same grace that they want given to them, because, just because your clinician doesn't know how to pronounce Ehlers-Danlos doesn't mean that they can't quickly get at least some grasp on what this is, and they can use their background medical knowledge to be able to get up to speed fairly quickly. And like you said, if they're willing to read and they're willing to learn and work collaboratively, that person can be so valuable, even though they started out like knowing what appears to be next to nothing, right?
Yeah, and I think that's often where a lot of the people who really specialize in these conditions, how they started. They had a patient and they were like, I don't know anything about this. I'm going to learn about it. And then once they learn about it, it's like, wow, a lot more of my patients have these than I thought. And they're starting to see those patterns everywhere. And then they're diagnosing people and they're saying, oh, it looks like you have dysautonomia. Wow, I think mast activation syndrome might be an underlying driver to what's going on with you. And they're suddenly putting things together for multiple patients that they, would never have done had they not started learning about these conditions because as we know, these conditions, are so much more common than they will learn about in medical school or, from articles. They come up so often. And once the word gets out that this doctor has, really helped all these people, then all the people start coming and boom, there you have an EDS expert locally to you. So I think, that really often is how it happens.
Have you been listening in on some of my professional mentorship sessions?
Nope.
That's literally how so many of them go. And yeah, and they may have somebody in their family who's affected or some personal reason to have more of a level of interest, but not always. I mean, I've worked with plenty of physicians who are like exactly what you just said. They have a patient, and then they find that as they learn about it. And so, yeah, no, that's super helpful. So, can we walk through what this actually looks like with a real world example of somebody trying to navigate this? We're going to give an example case of Sarah. Sarah is a 29-year-old woman who started having joint pain and frequent sprains as a teenager, but was told that she was, quote, just flexible. In her 20s, she developed worsening fatigue, dizziness with standing, headaches, GI symptoms, widespread pain, and difficulty functioning day to day that was increasing. She starts with her PCP, who evaluates basic concerns and refers her to cardiology for dizziness and palpitations. Cardiology focuses on orthostatic symptoms and recommends following up for other issues. GI evaluates digestive symptoms separately. The physical therapist notices significant instability, poor proprioception, and movement compensation patterns and raises concerns about hypermobility-related conditions. Meanwhile, Sarah is trying to make sense of everything through multiple sources, clinicians, online information, AI tools, etc., and receives different interpretations, including, quote, you're just hypermobile, quote, you may need genetics, and, quote, genetics won't change anything. I'm sure a lot of people right now are thinking, yes, 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 this is what I have been dealing with. At this point, she feels every practitioner is describing a different version of her problem, and every appointment leads to another referral rather than a connected explanation. How common is this scenario, and why do you think this keeps happening?
So, yeah, this is the story I have heard daily for the last decade. The details change, but the idea is exactly the same. And I think you can agree with that. It's the same story in different ways. And I think this keeps happening because most healthcare systems are designed around specialists who can be very siloed in their area of expertise, which is sometimes a really good thing. So if you need a knee surgery, you want the guy who only operates on knees all day, every day. But the downside to that is that it really makes it harder for anyone to see the bigger picture. And the system isn't usually built to connect communication between those specialties. So you get that person who is seeing dozens of providers and never getting and just bouncing back and forth. Oh, you need to see this one for this. Oh, I don't specialize in this. And, when you have, if you need a very specific, you need a knee replacement, you see the knee guy, he does the knee replacement, he's excellent. If you have a knee problem that doesn't require surgery and no one can figure out why you're having knee pain because each person is only looking like the neurologist, though there's nothing wrong with, your nerve function and that you don't have muscle weakness and you don't have this. And everyone's looking at their one area and no one can put together what's going on. And it takes someone who can really look at that whole picture and evaluate everything and say, okay, there are actually a lot of different factors that are contributing to this pain. And here are different approaches that we can take to help with those different things. So maybe it needs to be an orthotic in a shoe or different types of PT or gait training or pelvic floor problems that are, there are so many, everything in the body is connected. And when each specialist is only looking at through their one lens, things, often don't get put together in that big picture way.
And let's talk a little bit about the hammer nail phenomenon. The CSF leak specialist says you have a CSF leak. The May-Thurner specialist says you have May-Thurner syndrome. The Chiari specialist says you have Chiari. And I'm not saying you don't have all those things. The Eagle syndrome specialist says you have Eagle syndrome. And again, I'm not saying that a person doesn't have all those things, but you don't want to be going and having, 5 different surgeries when maybe working on stabilizing your mast cells is going to help your tethered cord enough that you don't need surgery, or it's maybe going to help your craniocervical instability enough that you're not going to need surgery. So can you talk a little bit about your experience with this hammer nail phenomenon? Because I certainly think that this is one of the biggest problems that people face.
Yeah, and I think that ties in so closely to what I was, saying just before, that each specialist is looking for what they're looking for, and it puts patients in a really difficult place of having to make those decisions, because especially if it's multiple surgical diagnoses, surgery, and especially some of these neurosurgeries, are really high risk, and it's not easy to decide. And how is someone who doesn't have that level of expertise going to decide, well, should I have the neurosurgery on my neck first, or on my spine, or on my, an abdominal surgery? Like, it's really difficult. And, I feel fortunate to be able to help people kind of walk through all of this. People come to us with, okay, I've just been diagnosed with all of these things, and they're proposing 5 different surgeries. And now what do I do? So, we can talk through with people and say, Let's start with the symptoms that are most impacting your quality of life. Which are those, and which of these diagnoses do those best match up with? And what makes it so complicated is that, like you said, sometimes there's an underlying mast cell activation disorder, that treating that can make a huge difference in pain and syndrome throughout the body. I had someone recently who was diagnosed with trigeminal neuralgia, which is an extremely painful facial nerve condition. And she did all sorts of different things to manage it, tons of different treatments. And then she learned of mast cell activation syndrome, and she went on a strict low histamine diet and started several different mast cell stabilizing medications and antihistamines, and her pain disappeared.
Oh, wow. Yeah.
That was so dramatic to me, because I've heard a lot of people say, like, "Oh, treating my mast will help my pain," and it's a lot of times it's a very subtle difference. But I have seen cases like that person where it really is a dramatic difference. And, you know, it's so hard. It's so hard to say. I'd love to hear from you kind of how people can try to figure out, like, is this just a surgical problem that needs surgery, or should I keep searching for something else going on? Because we also see people who are, should I be tested for chronic Lyme? Should I have my house tested for mold? It can be this really rabbit hole of trying to find, maybe there's something else underlying, something else underlying, something else underlying. And sometimes you have to focus on the problems that are more surface level. So how do you advise people balance that?
And I love that example that you gave, because I think sometimes it's easier if somebody has widespread pain to say, well, let's treat the mast cell, because then if you didn't take that approach, you'd be really doing a lot of whack-a-mole. So I want to first clarify the difference between, something that needs a more potentially urgent surgical intervention. So like, I know you and I talked about somebody recently with like a tethered cord type situation that was kind of rapidly progressing. So there's a difference between something that would be much more elective from a surgical standpoint versus something that is, definitely needing more urgent intervention. So what we're talking about now is somebody who does not need urgent surgical intervention, which of course is like by far the majority of people we talk to. By far the majority of people we talk to, they've been dealing with symptoms for a very long time. So if there's going to be any permanent neurologic damage, they've already passed that window, right? They're like way past that window, um, unfortunately. But I think that the example you gave about the trigeminal neuralgia is so important, because that shows that even in a very focal pain situation, and I've seen similar things, not necessarily trigeminal neuralgia, but I've seen similar things where very focal pain improved dramatically by addressing mast cell. And also patients who have had like severe craniocervical instability thought they were going to need surgery, but in the process of improving their mast cell and maybe treating mold or Lyme or something like that, not necessarily in a super aggressive way, because sometimes people get really, crazy with treatments for those things, improved their joint stability enough that they did not even need surgery. So I think that whenever possible, if we can take these more holistic root causes and address them, it's so much better, because otherwise we end up playing whack-a-mole, right? We end up having surgery for this and surgery for that. And I love it when I see somebody and they're like, they haven't had any surgeries. They haven't been dealing with the post-op complications, right? Because surgery is sometimes necessary, absolutely. But once you've had surgery, you get scarring and it changes things anatomically. And so then you have to deal with the ramifications of that on top of the underlying problems. So whenever possible, I think if we can address things like mast cell activation, I think that's so important. So what do realistic next steps look like in this situation?
If Sarah were my coaching client, the way I would approach this is I'd start by trying to help her narrow things down to her top two or three most functionally limiting symptoms. So, what are the top things that are really interfering with your day to day life? Um, and then I like to kind of map out what's already been evaluated across her different providers. So, what have people already looked at? What tests have you already had? What things have already been ruled out? So that we're not trying to duplicate things that have already been done. And then from there, it really becomes about prioritizing symptoms in order. So she can know what to focus on first and what's okay to just put on the back burner for now. Because in people who have so much going on like this, which is so many of the people that we see, it is impossible to tackle everything at once. It's not humanly possible. There aren't enough hours in the day. You can't do everything at once. And so that prioritization is really helpful. And then once we kind of have those priorities laid out, we can start to think about which types of providers are actually most likely to actually be helpful for these priorities. Um, and we can talk about the best way to communicate the need that she has with these practitioners. And I think it's really important to note that this process can take time. When people have so many complex conditions that are all interacting with each other, those priorities can change and very often in a positive way. So it's like my pain was my number one concern. I couldn't function because the pain was clouding everything. And now that my pain is so much better controlled, now I notice that all these other things are popping up and now we can look at those. But it's also really interesting how sometimes managing one area of someone's symptoms can have a ripple effect down the line. So, for example, very often people's main concern is, their top priority is fatigue and energy. They can't keep their eyes open. They're so exhausted. They can't work. They can't take care of their house. They can't do anything fun. And it's affecting so much of their life financially, emotionally, physically, everything. It's just overshadowed by this fatigue. And when we can work on ways to think about fatigue, and we that for another podcast, how we approach fatigue because it's very complicated. But as an example, someone has a sleep study and find out that they have sleep apnea, even though their doctor said, "You're young and you're thin and you're female. You don't have sleep apnea." But guess what? Because you have EDS, you actually, they found someone who will do the sleep study and they actually do. And they treated that and they're sleeping better. And suddenly, so many things can shift because they have less pain, they have more energy emotionally. They feel lighter. They can do things, and that turns things around and can start a positive spiral in so many ways. So, I think that it's not a quick. There are very few quick fixes. There are things that can hacks and tricks and things that you can implement right away that can immediately start to help. But in terms of the big picture, it's a process and it takes time. And I love to be able, when people come back and follow up and we can say, okay, how are you doing? What's next? How can we next? What problem are we tackling next? What are we approaching today? How did that visit go? What follow-ups do you have now? And that process over time can really, really help people a lot.
Totally, totally agree. And I thought of something interesting when you were talking about that another benefit of seeing people back is that sometimes people don't, myself included, we don't necessarily notice improvements because we're looking for and feeling when things are worse, but we don't necessarily appreciate when things are better. I was texting with a friend the other day. He was texting me on my birthday, and somehow it came up and he was like, "Wait, you don't have pain anymore?" And I'm like, No, not really. I mean, I every so often, like, if I injure something or whatever, but I don't have pain on a daily basis like I did. And he was like, "That's amazing," because he knew me from before. He knew before that I was having so many problems, and he had really been helping me with that. And I was like, "You're right. That is amazing." And and while I realize like how much better I am than I used to be, I don't think I was appreciating it on the level that he was able to by having like much more discrete snapshots. So when we have those discrete snapshots, I think we can help people have more hope because we can be like, look, last time I talked to you, you were really dealing with X, and now that symptom is so much better. And I think it really helps people to feel hopeful and understand that there are things that we can do. And that's the big reason why we do what we do, right? Is to help people understand that because they keep getting this narrative of, well, there's nothing you can do. There's nothing you can do. And that's so frustrating.
Yeah, it's so true. And I think, we described it earlier as whack-a-mole, right? So you're always hitting something. And when you're stuck in that feeling of always hitting something, you can lose how many you've actually hit, how many points you have up on that screen. Like you have like when people come back and it's like, wow, you like just a few months ago, you were so exhausted, you couldn't work at all. And now you're back to working part-time and you're functionally have improved so much. And yes, there are new things that come up, but you have made such great progress. And when you're in it and you're not, and life is always throwing new things at you and it's hard that different perspective can be really huge. So I think that's a really important point.
So, for the people listening who feel like Sarah, overwhelmed, confused, and getting different answers everywhere, what do you want them to hear?
So, if you feel like Sarah, like overwhelmed, bounced from doctor to doctor, playing that whack a mole with your symptoms, I would want you to really know that your experience is incredibly common and that you're not doing anything wrong. These conditions are so complicated and it really is truly challenging to coordinate it all. It really is hard. But there is a path forward and we've seen so many people who have really been feeling, very, very stuck in that place who have made tremendous progress. And I think it often starts in much smaller, more manageable pieces than people expect. Um, and, people think they're going to have to change everything and do these big things. And sometimes it's the small little things that can really change things around. And what I would want you to focus on next is not trying to make sense of everything at once, but by starting with those things that are actually most disruptive in your day to day life and then building from there. And instead of trying to piece together every single different message that you're getting from every different source, try to continue bringing it back to what is the main thing that's affecting my function right now and start with that and build from there.
And then that last bit is exactly what I tell people when they're getting told you have CCI, you have, a CSF leak, you have Eagle syndrome. Like, keep coming back to what are the most bothersome symptoms because imaging findings or, lab findings are one thing. But yes, that it's that clinical connection, right? It's making that correlation that's so important. So I love that. You've given us lots and lots of hacks already, but do you happen to have a hypermobility hack for us? Because that's, how we end every episode. And I know listeners love to hear our hacks.
I have so many hypermobility hacks. I was trying to pick which one to choose for today. I want to talk about AI because we mentioned it earlier, and it's really a tool that more and more people are using. And I think it can be a great way to generate ideas and organize information and learn about new ideas and generate questions to bring to appointments. So those are great uses for it. But at the same time, really important to remember that AI can also very confidently give incorrect or totally oversimplified information sometimes. So I think keeping in mind that it's a great starting point for exploration, but not the final answer.
Love that. Yeah, it's great for organizing your information. I encourage people to do that because you can take all your symptoms in a very disorganized list and you can ask AI to organize your symptoms by system. And that makes it much easier for the clinician to look at it and go, okay, these are the neurologic, these are the GI, these are yeah, things like that are perfect uses for AI. So I'm so grateful to you for taking the time to talk to me today. Before you go, I would love for you to share special projects that you're working on. And of course, this includes what you're doing with the EDS Society and things with the edu-coaching as well, and where people can find you.
Yeah, so currently I am a member of the Medical and Scientific Board for the Ehlers-Danlos Society, which is really an honor and a privilege, and it's been great to be able to work with them in that way. I'm also part of the Road to 2026 Research Committee, and over the past 2 years, we've been working on the classification updates and a bunch of different diagnostic pathways and treatment pathways and explorations in different articles that will be published about these different conditions. So stay tuned. Those will be published the end of this year, early next year. So that will be an exciting update. And yeah, I would love to work with you one-on-one. You can find me on the Hypermobility MD, Bendy Bodies, Edu-Coaching, and we'd love to work with you.
Well, thank you so much, Rebecca. I love this conversation because there's so many things that people need to know. And we're going to come back and talk about the rare types and red flags because I think that's going to be another important follow-up conversation. So people who have questions for Rebecca for our next conversation, please send those to us at bendybodiespodcast.com. And it was great chatting with you. So thank you so much.
Thank you. Thank you so much for having me.
Thank you so much for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, I offer one-on-one coaching and mentorship for both individuals living with connective tissue disorders and people caring for them. You can learn more about these options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at Hypermobility MD. As part of our collaboration with the UVA Ehlers-Danlos Syndrome Center, we also want to share some of their helpful resources. For questions or appointment inquiries, you can contact the UVA EDS Center at ruvaedscenter@uvahealth.org. Again, that's the letter R as in Robert, UVA EDS Center at uvahealth.org. You can find answers to common questions at uvahealth.com/support/EDS/FAQ. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements made on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider regarding your own care. For more information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.